Good morning. I'm Dr. Bill White again, and this morning I'm going to discuss a short video here with you. It's showing you where extractions can be a real big help in solving some orthodontic problems. Now, this particular case is a serial extraction case. Also, we're going to discuss how the slicing technique where you do the pulpotomies and reduce the deciduous cuspids to get the anterior teeth in alignment, and just show you how that worked, but it still didn't give us enough space in here to do the case. There's other things that we'll bring into this case too and show you. It illustrates those. It's not a long case, so we're going to go ahead. I need to tell you though that I'm a general dentist, and I've been doing orthodontics now for about 42 years, and that's all I've been doing for 42 years, and I practiced quite a while before that. Now, I'm in the American Orthodontic Society. I'm kind of pushing this organization. It's a great organization for pediatric and general dentists that are really interested in orthodontics. And if you are, this is the place you ought to get, in the American Orthodontic Society, and you can join it wherever you are in the world if you want to. It's a very efficient, well-run organization with one of the best CEOs in the country running it. So anyway, enough on that subject. Let's get on to the case. It's not a real long one. This is a young lady. These pictures were taken after we had been working on it for some time. It was a case that I just did gratis. I didn't charge them anything to do this for this family. Needed this, and so she's got a fairly straight facial profile, and we like to have a little more fullness where we do the serial extraction on anybody. She's got a nice smile line and everything, but there's a spot on that tooth where it came in with a discoloration, and some of the others have a little bit of this discoloration, and we've filled that, and from time to time you'll see it filled in here. Anyway, starting off with the case back in 1971, we wanted to get the 4 anterior teeth in straight and see if we had enough space in here to put the other teeth. You know, this is the molar back here, and we got a deciduous second and deciduous first molar, and this is the deciduous cuspid. Now, we reduced it down to almost nothing and did this pulpotomy on it. I'm gonna show you some things about doing pulpotomies on these teeth. I've done thousands of them and have never had one blow up on me, but I always did them on live vital teeth that did not have any infection in there, and we just used we used a long tapered diamond for a while, and then we just went to kind of a long shank carbide that was tapered off down, and we just go in and obliterate that nerve in that thing and grind the tooth down to what we wanted. And it was, while it was bleeding, we would pack zinc oxide and eugenol down in. Now, you've got to mix it up real stiff, and then you pat it out on a piece of paper or something that would absorb the eugenol until it's so stiff you can actually pack the stuff like amalgam, and you just pack it down in there while it's bleeding and everything. and I've done thousands of them. Never had one blow up, but I had an old surgeon do one time for on a case, and he just kind of smeared this stuff over the top, and it didn't work. It gave us trouble, but we were able to accomplish what we wanted to, even though the tooth went bad during that period of time. But I've done this on thousands of kids. We usually do 2 across here, and then we would come in and take the second deciduous molar down, and that's 4 on each arch, you see. So that'd be 8 for each case that we would do like this, and it really works. And I published a paper on this in 1969 or 70, and won the Cooley Award here in Texas on preventive and interceptive orthodontics. And the next year I had to speak to a whole slew of orthodontics at the state meeting for half a day, and I really sweated, but I came out fine on it. Well, back to the case we're doing here. I was going to try to bring this in, but I want to show you how these crowded teeth work their way in, and if you excuse me, if you just give them the room they need, you don't lose any arch length up here. But if you don't know how to do one of these, and you're just afraid to do it or don't want to do it, or for some reason or another, you extract the tooth. Well, these teeth move forward if you extract them, because you'll have more room than you need, and this will drift up here, and you'll lose some arch length in doing it. And so it's better to do these pulpotomies. And if you're going to even trim the tooth where you get close to the pulp, it's so much better just to do the pulpotomy. You can do it in a minute. You just take that thing and go down and ream that nerve out and pack it with zinc oxide and eugenol. I didn't use any rubber dams doing it, getting ground up in the thing. We just go in and do them just like you'd be doing a little filling or something. They're vital nerves, and I've done thousands of them and never had one blow up. But anyway, that's kind of illustrates. You can watch that thing, watch those teeth come in here. Now we trim some of the tissue to get those teeth to kind of line up, but you don't really have to do that. Now as these laterals come in, watch them just hug right up against that sliced deciduous cuspid. I call it slicing, but it's done with a burr, not a disc. You can't possibly do that with disc. You would cut into the permanent teeth. So you have to do it with a burr. Now watch them come in this cavity or this defect in this tooth. You also see some defects in the other teeth around, but this one was discolored, and so I'm sure this was a high fever or something while this child was very, very, very young when the tooth was forming. Now let's go to another one, and you see that tooth squeezing up beside. Now you can come in at any time during this. This tooth has no nerve in it. You can go in there and trim it a little bit more, and just stay off the permanent tooth. Though you have to be very careful. And this is the upper arch, and it's going to be terribly crowded. We have no room practically for the laterals, just some space that we'd close up in there to do that. So very little. On the bottom now, those teeth have come in a little bit further, and they're still slightly crowded, but they're not bad. Now after they finish getting in, you've got a patient with good function. They swallow right, they chew, and their tongue push these teeth out to here. I never put one thing as far as a brace on this child. Now we put some kind of a filling, or somebody did, in this tooth, and it looks pretty good at this when we took this picture. But when I get into the x-rays, you'll see now those teeth straightened up to that amount, and if we had had a little more room in here, you could have put the other teeth in this area, but we were really short of space on that side, so we went ahead and took the bicuspids out in another way that helped us too. So I'll show you that in a few minutes. Alright, this looks pretty good. This is 1973. Now we never put any bracket or anything on this young lady, bands of any kind. Now the uppers are coming in pretty good, but they just don't have room enough. The lowers almost straightened up ideals here with these trimmed deciduous cuspids in there. And just remember, if you extract the cuspid completely and you got more space than you need, this will drift forward and you will lose some arch length. And if you're deciding on whether to extract or not, and you want to, now you can expand it if you want to, come back in there later and put the teeth in there, but you're going to lose some arch length when you extract the cuspid instead of doing this pulpotomy and reduction like that. So the the pulpotomy and reduction is much better. Alright, here is the first panorex we took in 8 of 73. Now this is old stuff, but this is new to a lot of people. They don't know about what we're going to show you here. Now this cuspid is coming in and it's running right over this lateral root right here. You can see it's running into the root right up there. This one is doing the same thing over on that side. Now it is possible to expand this. If you have to expand it, it's going to take a good while in there, but we would put tip in these teeth like this, you know, not that much, but we would tip these roots over this way and get them here, and then try to expand some and get this tooth coming down beside this rather than down right on top of it, you see. This side's not as bad as this one right here, but in this particular case we decided to extract the first bicuspids. Now I want you to watch. Now this is that follicular movement of the tooth. If there's some tooth in the way of this, then it can't move over there. But if you eliminate this, and which we did, take the, well, I don't know whether we took that and this down here out, you see, and I'm sure you take the, so we just cleaned house all the way down here on it, which we'll show you in a minute. And I'm going to come back to this panorex. Now with the next one we had removed that, and without putting one thing in there, this tooth has moved off. If you look at this follicle around it, it's rounded out like that, and this one has two, and this one does also, this one does. Let's go back now and look at the other panorex. Now see where this tooth was, see where this one was, see this one's digging in over here. This one was in pretty good shape. It didn't have to do much. It just came right straight on up in there. But these three cuspids, the follicle rounded out. After you take pressure off of this side, this thing will assume a round circle, and it'll push this crown back in that direction. And this one will assume a round circle up here, and it'll push this tooth over in this direction, and it pushed this one in this direction. Now just watch. Let's go back and show that again. Now let me erase this, and look where that went to. Now let's go to the next one and see where it goes. This was 3 of 74. Let me see how. Now here we are in 1975. You don't see this patient every day or every few months or something. You take a look at it. Now this cuspid is completely out, coming in. This one's already in, and this one didn't need any help to speak of. But all of that took place because we eliminated the tooth on the other side and let that tooth drift back down in that hole. And the reason it did is this follicle around the tooth pushes it away. Now I wrote a paper on this years ago, but I don't know whether I ever published it or not. But follicular movement is something that every pediatric dentist ought to know about, because you can do a lot with your teeth by just bumping the follicle. You don't even have to touch the tooth. And if there's space on the other side, now this will run into this when it gets down, but this will come in without any problem at all. Now this is a good functioning patient, so you've got to have no tongue thrusts and mouth breathers and stuff like this. It'll work, it'll help, but it has this other force that it's got to deal with too. All right, let's go to the next one, and this is 1977, and the teeth are virtually in this condition without being touched with a bracer of any kind. Now that is worth knowing, and worth knowing how to do. I've had to do this on patients that had no earthly way of going to an orthodontist or doing anywhere. I mean, they were kids of missionaries or kids from places where there just were no chances of having orthodontic work. I've done this serial extraction procedure on a lot of them, and we get their teeth in pretty decent shape. Now these are not perfect, and it could be improved, but it can be improved when she's 40 years old if she wants to. So anyway, this is I think the last Panorex I've got on it. No, here's another one. This is 1986, and that was 77. And let's see, in 86, let's see, that's 9 years later, and the teeth are socked in better than they were. And now the wisdom teeth are headed in. Now, I'm not sure whether they all had room enough or not, but anyway, the wisdom teeth are headed in, and this is done with no orthodontic appliance in there of any kind, but a good functioning case, you see. So now let's look at, I don't think there's another one, but well, there is. So she had to lose her lower wisdom teeth, which the bone went up there, just wasn't room for them, so we had them taken out, and the upper ones will come in here and probably go into the gum back here, and they'll have to be removed. But you wait on it, Because if something happens to this tooth or this tooth, you can take this tooth and fill in and close the gaps up, which I've shown many instances where we do that. Use the wisdom tooth or anything behind to go in and take care of a missing bicuspid or molar or whatever in there. So let's go again. This is our cephalometric, and this is 1990, and the profile is fairly straight. Maybe not as straight as some people would maybe want it fuller, but she's perfectly happy with it, and she is. I'll compare her with her mother here in just a little bit, and we'll see. Now this tooth right here, the filling, I must have had somebody redo this several times. It looks pretty good there, but it gets stained, and so let's watch it. It got stained worse than an 86, and that's still got some stain on it. Now, I think there's no orthodontic appliance. I'm not saying you couldn't go back and really spruce this case up, or she can do it when she's 40 years old if she wants to. Now there's a filling that's improved. This is 1990. Somebody's gone in and fixed that tooth up for her. Now the midline's a little off, and that's 86. And 86, that filling got to looking pretty bad, but in 1990 they had it redone, and it's pretty well sucked into class 1. The midline's off a little bit. There must be something with the tooth size, because it looks like it's in good class 1 relation, but the midline's off slightly, and that doesn't look perfect right there. That's 1977. That's 77. That's 86. That filling kind of really deteriorated, and this is 1990, and her lip is over that, makes it look a little lopsided, but this is not perfect. But just think, there's not one single any kind of braces at all in there. So the function is pushing pressure here, and the lips are putting it out there, and that's where these teeth want to be, because that's where the pressure is pretty well neutral in there, and that works out, and you can use it. And it was very helpful to be able to take those bicuspids out and get the cuspids to come off the roots of these two laterals and come in like that. You know, we haven't touched her with braces. Now, to me, that's good orthodontics. If you can straighten teeth by just looking at them and knowing what to do, when to do it, and reducing the teeth or bringing them in or extracting them to get others to come in correctly, that is good orthodontics. But putting braces on teeth, it just got to where you think, well, you can't do it without doing that. But that's something we need to learn, how to do this follicular movement of teeth. And this is 77. That's 86, and there's 90. So and I imagine if I could find that young lady today, we got a little flaw right there on that. Not bad. You could have trimmed that or moved it. Now you could come in, and if she's 40 years old, you could come in and put some better torque in these rotations and fix them up a little better, and put those teeth in there nice. And I've had people that I did their teeth, they were in the mission field, and they came back home, they could go in and have them really fixed up fine if they wanted to. Now that side looks pretty good. Still, that cuspid is kind of edge to edge right down here. Okay, I hope you gained something from this. I'm going to show you the little girl and compare her with her mother. See, her mother looks a little more normal there, and this is her face, and here's the profile of the young lady, and the profile of the mother's pretty similar, very straight facial profile. And there's her smile line and her mother's smile line. So I hope you get to listen to this and learn something about things that you can do in the mouth. Sometimes an extraction will help you come out of a pretty good problem, getting those cuspids off the roots of the laterals. And then the other things, if you really understand it, you can do serial extraction, and the ones you do it on, if you want to come back after you get through and touch them up and fix them up nice, well, you can. It doesn't mess up the ability to come back and fix the teeth later on. So hope this gets your attention and you can learn to do this. It's a real essential part if you're going to work on young people. Thank you for watching, and we'll be back in touch. Bye-bye.